thank Tom and Brad and others for asking us to come and give you an idea of what the DoNoHarm project is. And it is a project very similar to the H2O, Healthy Hearts for Oklahoma. How many of you participated in that? That's what I thought, most of you all, and that's really good. This is what we call this is dissemination and implementation of the practice systems that are needed to put practice guidelines into operations. Everybody really knows about the law, the new law for the opioid prescription, and how it's really causing problems for doctors' offices, and I think even more problems for patients who really don't want, who have been stable for a number of years and really don't want those monthly visits and other things that are happening. In any event, what we want to be able to help you do, if you're interested, is to help you put into place all of the office systems that you need to meet the guidelines and the new Oklahoma law regarding opioids. We anticipate over the periods of this year to 2-year project, and I'm saying it's a year to 2 year because we are anticipating things are going to change over the next year, and that you're going to want to be on top of that as it is. So what we've done in this particular project have divided it into 3 broad goals. One goal is a quality of care goal, and that is, and the second is, or there are 4 goals: quality of care, financial security, joy in practice, and engagement in community. We're not even going to really approach you all with joy in practice, financial security, or engagement in community unless you want to, because those are things that are really built in to your CPC Plus activities that you've been engaged in. What we're going to focus on is the quality of care in 3 broad areas. One is better pain care. Second one is safer opioid management. And the third one is better mental health care. Now, since you all are in CPC Plus, you have already begun working on that integration of mental health care with primary care, but we'd like to come in and help you do some of the things that you want to do even further on that. If we look at better pain care, which is the first goal, there are 3 things that we will bring to you in that. One is a structured chronic pain assessment. Now, each of the clinicians has their way of assessing a patient with chronic pain, and it probably is fully adequate, but it makes it a whole lot easier if the staff are involved in that, so you make sure you have every one of the pieces of information that you need for that chronic pain assessment. And that's one of the things we'll help you work on. We'll look at what you have right now. Since you have Epic, and Utica Park is really spectacular in making sure the forms are in the EHR that you need to fill things out, this will go, I think, pretty easily. The second goal, so that's the first goal, is a pain assessment. The second goal, and this is one that as we visited clinicians around the state, they really are interested in, and that is a multi-modal pain plan for the patient. And it's really important for the whole staff to be on board with this idea of a multi-modal pain plan for chronic pain. Specifically, that means no medications first. Chronic pain is not very well managed with chronic medications. Now, there are a large number of patients in your practice, knowing the age of your clinicians in the practice, who we call legacy patients, and they've been being managed under the old guidelines for some time, and they're having difficulty getting them down in the opioid dose and getting them convinced that, quite frankly, behavioral health, and good news is you have behavioral health people tied in, but behavioral health treatment, particularly cognitive behavioral therapy, meditation, mindfulness, relaxation exercises, Tai Chi, it goes on and on and on, really do make a difference in chronic pain. In fact, chronic pain is a brain disease. It's a chronic brain disease. It's not a back disease. It is not a foot disease. It's not diabetic neuropathy. It's a problem with the brain's handling of pain signals. And so the treatment has to involve changing the brain. And we change the brain with these other methodologies. So that's the second thing that clinicians are really very interested in. The third thing is chronic pain assessment and monitoring to make sure that the patient is getting they're meeting the goals. And the goal in chronic pain is better function, not no pain. Everybody with us? So the reason this is important for the whole staff, and our practice facilitators will spend much of the time working with the staff, is the staff have to have that message to the patient before the clinician comes in the room, and that the staff are emphasizing that message for the patient. So the patient realizes they're getting this same message, not just from Dr. Mihalich, but from everybody in the practice. It's what we're saying. Okay, so that's better pain care, and that's the thing that people are truly most interested in. It'll be fun working with you all on that. The safer opioid prescription, I suspect you're doing all of that already. That is that every patient for whom we are prescribing an opioid chronically, that means 30-day prescriptions for 2 consecutive months in a row, those patients have to have an opioid consent at least once a year. And I'm sure you're doing that already, but that's something that the entire practice will be involved in. So the clinicians don't even have to worry, has that been done? Yes, it's been done, and everybody knows what to do. The second thing is the second is performing at least every 3 months, and some systems are actually putting it in 1 month, an assessment of the effectiveness of the multi-nodal pain plan. And we're recommending that you use the PEG score, and we've talked to Jeff and others about it, that I think that's already into the EPIC, and it's a very standard pain score. It's no longer the happy face deal. It is 3 questions. How much pain have you had in the past 30 days? How has it interfered with your life and your enjoyment in life? And the third question is, how has it interfered with your ability to move and function? So standardized pain assessment. The third thing is keeping checking the practice, or the PMP, which I'm sure you're doing and you have that built into the routine. The fourth one is, I'm going to forget something, I'm trying to do this from memory. I'm much too old to do this from memory anymore. Okay, so we have the pain assessment, the opioid prescription, the multi-modal pain plan using the opioids, urine drug screening, when random urine drug screening being done, patient and practice education. And the patient and practice education about opioids becomes really very important because of what I said, that we want the everybody in the practice to be on the same page, singing out of the same hymn book, their particular role. The third part of the quality measures here is what we're calling integrating behavioral health into the primary care practice. Now, the guidelines recommend that we do a behavioral health assessment on any patient with chronic pain who is on opioids at least every 3 months. And some people are doing it once a month. The thing that we're recommending you incorporate, if you haven't already, is the Esper Protocol, which has been developed by the SAMHSA. And what that is the use of the PHQ-9, checking for depression, which I suspect you're already using. It's a PHQ-3 screen, and then if it's positive, you go to 9. The audit, which is a screen for alcoholism. And quite frankly, alcohol and opioids don't go well together, and it amplifies the addictability of it. And then the third component is questioning about drugs, and you're already doing the big drug, tobacco screening. And it turns out that alcohol, drugs, depression, and tobacco increase the risk of a patient developing addiction to opioid. We are also urging that we have co-management with patients who are addicted. And let me see, do you guys use buprenorphine for addiction? Any of you have? Okay, that's not something. that's something that we're beginning to realize is an important addition to the medical practice, is the use of buprenorphine for patients with chronic pain, as well as for patients who are on the higher doses, that is greater than 90 morphine milliequivalents per day. It's very helpful to get them down off of those high doses. So that's what we do. We will provide for you a set of measures that take measures out of your PMP and put those together. So we'll give you a report over the past month, how many patients are in the practice who have a morphine milliequivalent dose greater than 90, and you'll get the list of those names. It's hard for you to get your entire list. I mean, it's easy to do, but it isn't easy to build into the practice. So how many patients have a benzo plus an opioid prescription, and how many patients have multiple prescribers who are prescribing an opioid? And so that's the PMP report that you'll get. And then we'll get a report from the EHR, which is the number of chronic pain patients, the number of chronic pain patients prescribed an opioid, that calculates our rates. And then we look at the patients who have had a opioid contract, have a PEG score within the past 3 months at least, and have had mitigation visit in the next 3 months. And a mitigation visit is measured by either a random drug screen or evidence of documenting the PMP. Comments, questions? Do you want to do this? Maybe. How much time is it going to take? That's a big difference. How much time is it going to take? Well, there are going to be 2 hours that I will come and meet with the staff, and we'll use, like we do with H2O, we have a summary of the facts and the evidence and the rules. And there will be a number of pieces in that workup that you may want to use as posters in your practice. So that'll be 2 hours of continuing education. And then the other time, Kathy Vu, and who else will be?
It's Tina. Tina's really going to be the primary.
Tina's going to be the primary here, practice facilitator, and she will come into the practice and work with the practice manager, with Central Utica Park, with the staff, mainly with the rooming staff, because there are some rooming tasks that need to be put in, and they'll work with the EHR to get the reports out. So a lot is going to happen in the background, and a lot will happen as the staff wants it, but the time that the actual clinician, it's going to be up to you. You have a question, you have something you want to talk about, then we will be available to do that. And I will be available by phone and when you need anything. Yeah, Tom.
Okay, so if I know my partners very well, I think I do, we're all thinking, okay, how much is this going to take out of my day? Is this going to be like when Kathy came by for H2O, it was 5 minutes, we talked about some issues, and she gave me some data reports, and that was it?
That's it.
And then she'd come back a month later?
That's exactly right.
Okay.
Kathy will probably be here, Tina will be,
Right.
Tina will be here probably twice a week, but she won't be interacting with you more than once a month, unless you call for it. You know, you say, I need to talk to you about this, this, and this, what do we do here? Otherwise, she'll just be there to give you the reports. I think those take about a 5-minute conversation, actually.
Right.
And to the degree that you can do that as a group, it may save your time. On the other hand, many practices, we can't get together as a group, so Tina will go to each individual that has lots of experience doing that.
And sometimes that works better anyway, just as far as the
Exactly.
education.
Exactly.
So the next question is this something that would be better served if each and every one of the providers here were involved in it, or do we just need one champion in the clinic?
This is one where it really works better where every provider is involved. And that way you guys have an opportunity to develop some standardization and efficiencies in standardization. In H2O, it wasn't that important because, well, it just wasn't that important. Here there are all of these standardized processes that you want to be able to pass any audit for. That's the number one deal. And the number two deal is you really want to improve the quality of care for these patients. Mainly the chronic pain patients that are not on opioids. That's one big one. And the other one is get the opioid doses down far enough that you're not dealing with overdoses or patients who are becoming addicted. The last thing we want to say is, and this is going to be a hard one, is changing the attitude that addiction is not a moral failing. Addiction is absolutely a complication of using opioid medications. Anybody who takes an opioid medication is at risk for addiction. Okay, that's really important to know. And if we become addicted, it's devastating to the individual who is humiliated and shamed and all kinds of things. And that's why when we have an attitude, oh, this is just another chronic disease like diabetes. People can be ashamed that they have diabetes, but quite frankly, we work with diabetes and we'll help you live a good life. We'll do the same thing if it's addiction as well.
You might mention the CME program that anyone can take.
The CME program is available. There are two CME programs that we will have available. There's one that's online that was supposed to be available a month ago. I think it's coming out next week. I don't know. It's a 6-module CME program that takes 3.5 hours to take. You don't have to take all 6 modules. You can take any ones you want and in any order. Clinicians, advanced practice nurses, PAs, all can get CME credit for that, for respective CME credit. The one group that can't is the osteopathic physicians.
But anyone can take the courses that are on the Departmental Health website.
Yeah.
Then at their option, they can transfer over and actually get registered for CMEs.
And Tina will have the materials to get you signed up on that. Second thing we have is we have the PI CME. And PI CME is Practice Improvement CME, and that gives the clinicians, all of the clinicians, 20 hours of CME credit for working on improving the practice. It's a particular kind of CME, and that you get at the end of the study. And all you have to do to get that is to participate in it and demonstrate through your comments that you have looked at the measures and you've done some things in the practice to change it. Okay, Tina, have I missed anything?
No, I think you covered it all very well.
Do you want to stand up? Have you been introduced?
Yeah.
Okay, Tina Breedlove is your primary practice facilitator, and Kathy Vu, who's standing up, is a secondary practice facilitator. We have a number of people who can help out. Any other questions? Tom, did that get all your?
I think that covered my questions.
I had a quick question.
Yeah.
Okay, so I have some patients who, since the law went into effect, they don't want to go through all the, and they want to get off the medication. Do you have some, can you help us wean those patients off?
Absolutely. We have a weaning protocol that the CDC has put together. It's really pretty easy. If they're in the 90 morphine milliequivalent range, you know, if they're higher than that, you may want to go slow on the weaning, maybe 10% a month. Some people even need to go slower than that, depending on how they respond to it. The problem with weaning is you really pay close attention to the withdrawal symptoms. And the major withdrawal symptom that people have is anxiety. So then they come in asking for a benzo, and you're into this terrible mess. So what you want to do is say, anxiety is what's going to happen. You're going to feel fearful. You're going to feel anxious. And we will go slow, but you never go back up. You just keep going down and down. And it's going slow. At the 50 morphine milliequivalents, we've had a number of practices where patients come in and say, I've been reading about this. Here's what they say. It's really great. And doctor, I don't want you to get into trouble. Therefore, I want to get off of this. And a 50 morphine milliequivalent, you may be able to do that in a month, you know, reducing it by 10% every week, and it will go pretty well. But you use the patient's response to it, because there's no formula that works best. You just want to keep them really comfortable and know that, and that's where you all come in. Because the patients are going to call and say, hey, wait a minute, I'm having this problem. Well, you need to talk them through the anxiety and keep them on the dose. Okay? Great question. I am amazed already how many clinicians in Oklahoma have reduced. I mean, I think we're going to be blown away by the average morphine milliequivalent dose of patients in Oklahoma, even after a year since the law's been out.